Couple of handouts to you. One is an example of the Braden scale. Now this is used, we do this once a shift. Okay, I usually do it at the beginning of my shift so that way it's done, it's out of the way, I don't have to worry about it. And it also shows that I've done my skin assessment at the beginning of my shift when I'm looking everything over. Okay, there's several different things on here that you do need to be aware of at least. The different topics that we are looking at. So one is sensory perception, then there's moisture, activity, mobility, nutrition, friction, and shear. Okay, and it has the nice definitions of each thing there. The lowest possible is a 6 on here. The highest is 23, okay? Depending on how you score your patient, some facilities will say, if their score is low risk, you have to have, A, B, C, and D in place to make sure that there's no risk, okay? If they're high, then you have to have what would be a low risk, a medium risk, and the high risk patient in addition to these other things, okay? All those interventions, all right? How often do we do our skin assessments, though?
Is it once a shift?
We have to document it at least once a shift, but we are going to continually be assessing with every turn and reposition, okay? So, this is a nice little handy thing to do. You do need to be at least familiar with the different categories that are evaluated, okay? As far as, what to look out for. So, sensory perception, it says here, completely limited, does not moan, flinch, or grasp to painful stimuli due to diminished level of consciousness or sedation. Right there is my cup of tea as far as the patient is concerned. Intubated, sedated, and doesn't need a call light. Okay? They can use the call light, get them out. But we have different ranges here as well. We can go all the way up to response to verbal commands, has no sensory deficits which would limit ability to feel or voice pain or discomfort. That's your walkie-talkie, not my type of patient, that tall, okay? Then we have moisture. What kind of environment is their skin in, okay? Does not necessarily mean that they're soiling themselves or anything like that. Are they diaphoretic? That's going to put moisture up on their skin as well, okay? With excess moisture, what happens to the skin? It rubs off a lot easier, okay? It can cause skin breakdown way faster. Activity, we have bed fast, chair fast, walks occasionally or walks frequently. Mobility, completely immobile. So that would be your patient that is contracted and is not able to move on their own at all, completely dependent on us for even just adjusting them in bed, all right? Then we have, goes all the way up to no limitation. Again, your walkie-talkie. They're the patient that's walking around with their IV pole around the nurse's station 3 or 4 times a day or however many times. You don't have to sit there and tell them to do it, they just automatically do it, okay? Nutrition. Now, how many of you guys know what TPN is? No. TPN is total parietal nutrition. We are feeding them through their IV, okay? It has its own set of complications with it, which you guys will learn later on, but that is still a source of nutrition. So here it has, never eats a complete meal, rarely eats more than a third of any food offered, eats 2 servings or less of protein, such as meat and dairy products per day, takes fluid poorly, does not take a liquid dietary supplement, and they are referring to a protein supplement. Okay.
You said TPN was what? Total?
Total parietal nutrition.
Okay.
And then down here it says, is NPO and or maintained on clear liquids or IVs for more than 5 days. So if they've been on TPN for 2 weeks, they're automatically already down there for very poor, okay? TPN is very dangerous. You would think, oh, not so much, but they change the order and the construction of it every day. And each bag, if memory serves me right, and if there's any pharmacy techs in the class, let me know. But they're about $4,000 to $6,000 a bag, and they get a new one every 24 hours. Okay, so yeah, and they're custom made for each patient depending on what the doctor has ordered, based off of labs and how they're performing and all that fun stuff. And then friction shear. Now, what's the difference between friction versus shearing? And don't say Ed shearing.
Shearing is like when it comes off, right?
Well, you can get that from friction too.
But like friction is the shear.
Carrying.
Shear. So, because we have that nice little extra fat pad that most older people don't, okay, our skin can move underneath it, okay? Friction is direct skin pressure, but shearing is when there's movement and then pulling against that and causing the skin to kind of slough off. That's shearing, okay? We used to have a problem with the Hill-Rom beds that were similar to that, but they had channels in them that would deflate and reinflate, and it would turn the patient. But if you didn't have them perfectly on the center part of that mattress and it deflated, they would shift as it going from the different surfaces, and it would shear off the skin on their backside. So then we'd say, okay, well, we're not using this anymore. So then you take however you've rated your patient and add it up, and you get that lovely little number. Hopefully it should be closer to 23 and not so close to 6. Okay? And then there's also additional resources here on the back for you guys to look at, should you wish to. Okay? But just know you need to be familiar with these categories. Okay? All right. The other handout that I gave to everybody looks like we're going to have a dance class, but it's not. Okay? So there are different gaits that we utilize depending on what we are utilizing as far as assistive devices. Now what you have in front of you there are the several different types of gait associated with these guys. How many of you guys have ever had to use these? They are a pain in the tuchus, okay? Now, we have a couple of different items on there. Now, not all crutches are the same, okay? These are regular crutches, but then there's also forearm crutches. Have you guys seen those? Mm-hmm. Those are the ones with the little cup that hang on the person puts on there, and they can lift their hand up, and it, they don't have to hold on to anything. So typically you'll see those with people with like MS or cerebral palsy or anything like that, and they will utilize it to help stabilize them. Now the first one we have is a 2-point gait, okay? And that kind of makes the person look kind of like an AT-AT in Star Wars. You guys know what the AT-AT is? When they're on the Battle of Hoth? Yeah. They got those big things that are doing this, okay? Told you, movies and me, man, I'm telling you. So basically, they'll have their forearm crutches, and they will step together, but on opposite sides. Okay, and that is them doing a 2-point gait. All right. Then we have the 3-point gait, and that's what everybody is the most familiar with these types of crutches, okay? Because maybe my knee, I had knee surgery or something, and I'm having to get around like this, okay? My parents' insurance sucks, and I can't get the little knee scooter and just kind of hang out with that. All right, that's the old school.
And that was painful.
This is so painful too. Okay. You want to, okay? But I'm also kind of going like this. I shouldn't be doing this swinging further up there, okay? Which is one of our options. Then we have the 4-point. This is when you take a step first, and this is again one of those forearm versions, okay? So the person's stepping first, and then bringing it forward. Stepping, bringing it forward. It feels weird.
Yeah. I've never seen that.
No? Or no, wait, actually they're doing it this way. Apologize.
Oh, okay.
So
My
walking
bad.
normal?
They're kind of walking normal, but they're utilizing those crutches instead of it being opposite, like before. Okay.
Is it almost like two canes, basically?
Then we have the lovely swing 2. Now this is for, they'll put the crutches forward and they'll swing to it, almost like they're hopping. I'm having to do that right now because these are too small. Okay. Or there's the swing through, which is basically the same, but
Seems very efficient.
6 weeks on these things, it sucked. Okay. These are not the most comfortable. There is some safety things that you need to be aware of. Now these are nice in that you don't have to guess where to put these things and constantly be like fitting, because it tells you right here along the side if your patient is 5'5", which I am not. So we're gonna have to go up, because last time I checked, unless I'm shrinking, it's 5'8". So I put that there, and it fits just right where it's supposed to. We don't want them to be resting on it like this, because what's going on in the armpit? There's circulation, there's nerves and everything else, and if they lay on it like this, their hand's gonna go to sleep, or their arm's gonna go to sleep, okay? We wanna make sure that if they're using both, that they're not doing this either. Unless they're Quasimodo, okay, then by all means, we'll do that, all right? So much fun. Now, across the top, it has different indications as to what most likely would be the best thing for utilizing that type of gait with crutches, okay? Partial weight bearing, full weight bearing, all those fun things, all right? That's probably the most important part of that graphic that you have, okay? Then, and I hope you guys are paying attention because you guys are going to be playing with these in a little bit. Well, not playing, be experimenting. Then we have these guys. I have these situated on Wednesday. There we go. Oh, you brought your hurricane? So we have a couple of different ones here on the campus. You have a single point cane, oddly enough, okay? And then you have the nice little 4-point cane. What's important about these, the 4-point, if you look here, one side's kind of flatter, and that's the side that is supposed to be along the side of the patient. Okay, that way they, in theory, aren't going to trip on it. All of these things, because they're assistive devices, they increase your patient's fall risk tremendously, okay? But, you guys remember is it mnemonic or an acronym? Be an acronym.
Acronym.
For cane usage. COAL, C-O-A-L. Cane on affected, that's the word I was looking for. Affected leg. Yeah. Opposite, yeah. Cane opposite affected leg. That's where the opposite is. All right. Whether it's a 4-point cane or a single point cane. So, if my left leg is the one that I'm having issues with, okay? I'm not gonna walk like this, which is typically what we see people doing,
All the time.
okay? The purpose of this is that I move out with my affected leg and my cane is opposite it, and then as I advance forward, I'm putting all of my weight here instead of on here. And then I can put all that pressure there, not as much on my knee, and move forward with my good leg. And then I do the same thing. This is how they are supposed to walk with the cane, okay? Not
Looking like
like
robots.
this, okay? So this needs to be about hip level, if it's, for their leg or anything like that, okay? because we don't want them to go too far ahead of them. All right. We don't want it to be up here either. We want this to kind of like be a fulcrum for the most part. All right. Then we have these lovely things, which my mom has one now. She's been having some falls and stuff, but hers is more of a Cadillac. It's got brakes and it has a chair that she can just sit in. Yeah, she loves it now. She's like, now I have a place to sit my purse. Because underneath the seat there's a little bag for her purse. But this is just a regular front-wheeled walker. And this one's nice in that it has these little slidey things. Typically, what do you see on these? Tennis balls. And that is so that it's easy to move it across different surfaces.
And you
Okay.
will see them also where the wheels are on the back side and they put tennis balls on the front. So it just
Mhm.
depends on the manufacturer.
Yeah, well, and too, because if it was opposite here, and maybe I just need some help, maybe I can't lift it, or just move it forward, but I can tilt it back and move it forward, like this, to do what I need to do, okay? But, with a cane, we want them to advance it first, and step towards it, okay?
Show them how they usually walk like
Yeah.
that. Zoom.
Okay. And hey, you know what? If that's how they get around and they feel secure, fine. Okay? But what is supposed to happen is they move
The
the
other
walker
thing is,
first and move towards it.
they need to stand up, not like this.
Yes. That was one thing my mom did when she first got her walker. She was like, I'm like, Mom, you gotta be walking upright. So I had to adjust it for her a little bit. So, one thing we do not want our patients to do with a walker, I was gonna sit down. We do not have them hold onto this and use it as leverage. Okay? These things are top heavy. And if they hit it at just the right angle, they're gonna tip over. Okay? What they need to do is get to a standing position first, then utilize it. Don't sit there and be like, okay? So they're not supposed to use this as leverage.
Contact.
Huh?
Contact.
Right. Questions? Comments? Concerns? All right, I want you guys to teach each other how to use a walker. I've got one set of crutches, I've got one walker, I have 2 of each of these. So we have an extra 1-point cane over there and another 4-point cane. All
If
right?
y'all really want to